Okay.
I just want to welcome everyone again to the session today by John Olson, who is going to continue to talk to us about ventilators and ventilation, if you will, and the physiology. And today he has a topic, as you can see from the screen, ventilator waveforms, which is probably going to give us a good education about the physiology of what happens to both the humans and to the machines. So, John, you know, the floor is yours, please.
Okay. So, so let's start. I'll start going here if I can make my computer work. Let's see. Oh, there we go. All right, so we're going to try to look at some scalars and pressure volume and maybe some flow volume loops. And we're going to try to see what we can find, how the patient's doing by looking at these. Also, we're going to look at compliance and resistance, because that's a big thing, a big part of what we do as respiratory therapists to look at the compliance and resistance. And actually, it'll help you physicians also to look at some of the numbers and normals and how you identify some of this, some of these things. I have put a couple examples in my PowerPoint about with certain ventilators. So usually all ventilators can measure plateau pressures and compliance and resistance. You just got to figure out how your ventilator does it itself. So let's do, okay, so we're going to monitor ventilator function, evaluate the patient's response, and evaluate and monitor changes in lungs compliance and resistance. So let's just look at some of the scalars. So you can tell what kind of waveform you have. You could, by looking at either its flow or pressure, and you can just tell I can tell by just looking at what that waveform looks like. I don't need to have something out to the side tell me it's flow or waveform. And you can see you got flow can come in square waveforms or sinusoidal or descending. Most of the time we only use these two right here, these descending and rectangular or our square waveform for our flow. So a constant flow pattern or that square waveform delivers that flow, goes up and gets to that flow that you have set really fast, delivers it, and then once it delivers that volume, it stops and comes down and you go into expiration. And if you notice on this flow pattern here, that the flow actually goes negative. So you have inspiratory on top, and it goes down to that zero baseline and goes into expiratory. And there, you can see there's the flow on the left side and then time, as you will, on the bottom. But just notice that that's one way you can tell what kind of flow, what kind of pattern you're looking at. If it's flow, it goes negative. No other pattern will go, pressure doesn't or volume doesn't go negative. So that's just something that you can look at that ventilator and you can see those pretty quickly. So here's a 8400. It's a Pearson and Bennett model. These are actually, it's a 20-year-old platform. We use a lot of these. There are a lot available out there. Especially after this COVID, people are just buying them up, and they're not very expensive ventilators. Where some of the newer ventilators are a lot more expensive. And you can see right here, that's a square waveform, and for the flow, and it goes up, and like I said before, it gets up to the flow, keeps it until it delivers the volume and drops down. And you can see that up on top, that's what the pressure waveform looks like for that. And then the descending is the second one that's over there, and it actually delivers that a little more gently as you would, but it takes a bit longer time. And so there are certain situations when you'd want to use either the square or the descending. Most of the time I use descending for most of my patients, but if I had an asthmatic where I had to deliver that flow quickly, I would use the square or the constant flow pattern. Okay.
Am
I talking too fast or?
No, so there is a little echo, so I don't know if your speakers are, and I hope everybody's muted. So, but keep going. I think you're not talking too fast, but these are really concepts that are that need a little bit more elaboration. So you can take a minute or so longer to really spell it out in terms of the dynamics.
Okay. And then here's some more of the same flow pattern. So you still have that square flow pattern. And again, remember when I told you, when we look at flow, flow goes negative. And then the pressure waveform is coming to a point. So as it's delivering its flow, as it gives its flow and it's delivering that volume, it goes all the way up to the peak. It gets a little pointy head there and then comes back down for the pressure. And you can see the volume on the bottom, and so it gets that peak about the same time it hits the top of that volume and patient goes into expiration. Okay, and this is the descending waveform. So this is the one that we use most of the time. Like I said, it's more comfortable for my patient. It doesn't give them the flow so quickly. It can also help deliver that, by delivering that volume slower, it can help open up the airways more. You can get more airways open that way, only because by delivering it slower, you're going to give it more time to fill up the lungs. Because again, this isn't the natural way people breathe. You and I, when we breathe, we take a breath in, our diaphragm drops, creating that negative pressure, and we actually, by creating that negative pressure, we open up a bunch of alveoli. Well, these are people that have a tube down their throat, and they're getting positive pressure. That's, like I said, not the normal way, and so that pressure is going on the path of least resistance. So what I mean there is, if you have a pneumonia on the right and you are good on the left, your lung is open on the left, it's going to want to go, a lot of that flow is going to want to go to that left lung, because it's pushing that, it's using the pressure to push that volume into lungs. And sometimes that's not really what you want when you're trying to ventilate somebody. Here we go. This is a it didn't really come right here. All right. Oop. Let's try to go back. All right. So this is again the pair to Bennett here, and so I had some questions last time where people were asking me, like, where do I find minute volume, and where do I find tidal volume, and where do I find respiratory rate? So you can see up on top on this ventilator here, it says peak, peak. So that's your peak airway. That's the amount. It's a dynamic measurement. It's the amount of pressure it took to deliver this volume inside the patient's lung. And the mean airway pressure, and so that is the average pressure over time. So if you look where my arrow is, underneath that curve here on the pressure curve, you can see that's your mean airway pressure. It's going to average that out over time. Mean airway pressure equals open alveoli. Now you get to a point where you over distend them, of course, if you have too much pressure. But that is the amount of pressure it took to deliver that breath. And there's that PEEP. I have my PEEP down here set at 5. It's at 4.7. It's pretty close. And then the inspiratory to expiratory ratio. So you and I, when we breathe, our inspiratory to expiratory ratio, or I/E ratio, is 1 to 2. So our 1 to 3. So some patients need a longer expiratory time if you have maybe an asthmatic or a patient with emphysema or COPD. They may need a longer time to exhale. So we can adjust that by adjusting the flow down here. If I push in that breath quicker, I can get I can get that expiratory time. I get more expiratory time with that, okay? And then there's tidal volume right there, so VT. So our average tidal volume is about 400 to 500 mils. This is in milliliters. So the other one here with the V and the dot over the top, that's minute volume. So that's the amount of volume in liters over a minute that it delivered for your breath. You know, that's how many, that's how much volume you've gotten over the minute before. That's just the time, that's your minute volume. So let me go past that. All right, here's some more. So again, remember, there's your peak airway pressure. There's that mean airway pressure, and you can see my PEEP is up a little bit. So it's at 11, it's set at 11. So you can see my mean airway pressure is higher. So I'm actually opening up more alveoli with that. So there's that tidal volume, and then again, that minute volume on the end. So that's where you find a lot of these numbers on these screens, is you'll see them. They'll be all in one area, and you can see they'll change with each breath. So so on your ventilators, just take a little time and look at them. Again, we have the two scalars here. I have a descending flow pattern and then and there's my pressure pattern down there at the bottom. All right. All right, so here's triggering. So patients can trigger extra breaths when they're breathing. So this is assist control here. This is so there's your pressure waveform, and you can see right here, there's a place where the patient triggered a breath, and here they didn't. They got a breath delivered to them. Here they didn't trigger that breath. And here again, they did trigger that breath. So you can see when the patient triggers a breath by looking at that little indentation or the dip in pressure right there, okay? So I can determine my modes. So if I had a patient in SIMV, I can look at these flow patterns, and I can see these descending flow patterns, and here's my square wave. So this is a mandatory breath. You can see, remember I told you by the pressure comes up to that point about equal to the volume point, and then comes back down. And pressure support, that's more of that spontaneous mode. Remember I told you you are riding that bike up the hill, and I come behind you and I push you. I just give you a little boost, and that's what that's doing. That's a little pressure giving you a boost. It goes up to a certain point that I set, or you write the order for, and I set it on the ventilator, and that actually helps them overcome the resistance of the ET tube. All right, let's see. All right, we'll talk a little bit about lung compliance. So this is very important. Lung compliance tells you how stiff somebody's lungs are, especially with ARDS. We need to watch our lung compliance and our plateau pressure. In 2000, there was a study made by JAMA that we still use, the Journal of American Medicine. Anyway, so we still use that, and it stated that if we can keep our plateau pressure, which is that pressure with an inspiratory hold that we measure on our vent, and if it's under 30, we can help keep our lungs from getting damaged. This is a static maneuver, so we have to do a breath hold. Normal lung compliance for you and I, and we can use this to measure lung compliance. You can see the formula up above. It's the tidal volume divided by plateau pressure minus the PEEP. And that's how I get my lung compliance. So I need that plateau pressure. So JAMA just thought, we'll just take that plateau pressure, and then we can show people. It's an easy thing to measure. we can show them that we can keep our lungs healthy by keeping that plateau pressure under 30. So here we go. I'm gonna show you how you do that on this machine here. So this again is a 840. So I have the inspiratory hold. So down at the bottom of the screen, I wish I should have showed you that part, but there's a little button that says inspiratory hold. On all machines, you can do this. You can do an inspiratory hold. There's not one that you're not gonna see that can't do this. So I do my inspiratory hold, and you can see down here in flow pattern, there's no flow here. So I do my inspiratory hold, and then I can get my static compliance and my plateau pressure up here on top. And actually, since I'm in the square wave, I can also get airway resistance. Okay, so I did this with a test lung. It has a little hole for expiration, so of course my airway resistance higher than I'd really want it to be, but my compliance in my lung was pretty good. So are they're actually pretty stiff, but it's 23 mils per centimeter of water pressure. You and I again are about 80 to 100 centimeters, or milliliters per centimeter of pressure. So the easiest thing to look at is that plateau pressure, though. If you can look at that plateau pressure and you see that mils per centimeter of water, you and I, again, are about 80 to 100 centimeters, or milliliters per centimeter. Am I going too fast?
No, you're not. Tariku, can you mute your phone?
Thing to look at is that plateau. Oh, I hear it, yeah. You can look at that plateau pressure. That
John, keep going, please.
okay, that's right. So like I said, the key is to look at your plateau pressure. If it's less than 30, you're not gonna, you have a less chance of hurting the lung of the patient. So this is a GE care station, and I know they have these at St. Paul. So anybody out there from St. Paul, you can use this to measure for your patients. So here I got you go into procedures and you do an inspiratory hold, and then you can measure your plateau pressure, and you can see mine is under 30. So I like to make sure that my patients are not getting too much pressure. All right. Airway resistance, so that's plateau pressure minus PEEP, and then divided by flow. So why do I care about airway resistance? So if my patient is having trouble exhaling, then maybe that's something I need to worry about. They have COPD or asthma. I need to look and see how high that is, because that can actually affect how much pressure it takes to deliver the breath to my patient. Again, this is a static maneuver. I need plateau pressure. So there's no flow. It's not a dynamic thing. And we can only measure it in the square wave. Normal is about 2 to 5 centimeters of water pressure per liters per second. But if you have greater than 10, it means that there's some kind of problem there. You may have excessive secretions, or I know they use a lot of filters at the patient Y over there, the HMEs. They get clogged at times, so it's time to change your HME if it's going up and up and up. Bronchospasm, leisure, the patient's biting on the tube, or maybe there's fluid in the tubing that's in there and needs to get drained out. All right. So again, you got to have it in the square waveform and no flow, so you can see the patient gets their breath and it delivers, and at this plateau right here, it has no flow, and then I can get my my airway resistance. So my airway resistance is high for my test lung, so for the test lung that I use. this is another thing. So this, you can see this is showing you that that here's your airway resistance going up here to that plateau pressure, and then I get my static compliance or my plateau pressure. I need them both to measure either airway resistance or plateau pressure. So you got to do that inspiratory hold on your ventilator, and you got to figure out where that is, so you can measure these and know that you're keeping your patients safe. Okay. All right. So there's another way. So if I have a patient, how do I know my patient pressures are really high? How do I know if it's because of airway resistance, or is it because of their lungs are stiff, they have ARDS, or they have pneumonia or something like that? Well, you can tell by the difference between your plateau pressure and your PEEP. So if you have a big difference between there, if you have increased pressure difference between your plateau pressure and your PEEP, then you know that that's probably due to the increased airway resistance and not because my patient's lungs are stiff. You know, they may have pneumonia, but maybe they're not stiff. You know, they have secretions in the airway, or they're having bronchospasm or something. But if there's only a small disparage, like 2 to 3 or 4 centimeters between your PEEP and your plateau, then you're not looking at so much airway resistance. You're looking at it's more stiff lungs. All right, so you can see that your airway resistance is this area here in between your PEEP and your plateau pressure. And you can see this is increased over here on this side, as opposed to this one, it's a lot closer. This can help you determine what's happening with my patient. Does my patient need to just get suctioned, or maybe they just need maybe they're in ARDS and I need to be treating that like that. So we'll talk a little bit more about weaning patients. I know I talked about it last time, and I think I went too quickly. Most ventilators, again, can give you the information that you need to do this. At my hospital, and most hospitals, they use what's called a rapid shallow breathing index, which is a RSBI, and that's a respiratory rate divided by tidal volume. So tidal volume's in milliliters, okay? A good value is less than 105. So if my patient's rapid shallow breathing index is less than 105, then I'm doing okay with my patient. They're ready to extubate if they pass all the other criteria. If the patient is on the ventilator, I put them in CPAP mode, which I'll give them CPAP of 5 and no pressure support. So they're going to have to work a little bit to breathe through the ET tube. But if I get, like I said, a value less than 105, I'm pretty happy with that. So here we go. This is again the 840, and then I got 0 pressure support here, and I have them in a spontaneous mode, and you can see I have them set on 5 of PEEP or CPAP. There's no extra pressure in there, and then I can hit this clipboard here on this ventilator here, and it'll give me this frequency to tidal volume. And so that's my RSBI right there. That's my rapid shallow breathing index. And so it's 78 for my patient. So they're actually, they're ready to extubate as long as they pass the criteria. They're mentating, their oxygenation's good, their volumes are good, you know, or their minute volume is not too high, you know, stuff like that. They can cough. And then if they pass this part, then they're ready to extubate. We can get patients off the ventilator a little quicker. We do this at least once a day at our hospital, and sometimes twice a day, to try to see if my patient's ready. The quicker I get them off, the less chance they have of getting ventilator-acquired pneumonia, which is going to give them a longer time on the vent. We don't want that. This is how you do it on that GE care station. Remember we talked about that. I said it's probably, I think they have them at St. Paul. I'm sure, in fact, I'm sure they do. So I can go into this vent setup and put my patient on the settings that they need to be, and then right down here in the corner, it's going to give me that RSBI again. See, I can see that RSBI. We're doing good. So my patient's can come off the vent if he meets all the other criteria. Spontaneous breathing trial. So after I do the RSBI, we usually put them on a spontaneous breathing trial just to see how they do. It's more insurance for us. So we'll put them on 5 of pressure support and 5 of PEEP, and we'll put them on there for about 30 minutes to 2 hours. So and then if they still look good after that, then of course we're ready to extubate my patient. This is while they're on the spontaneous breathing trial, or SBT as we call it. We like to watch some parameters like making sure the respiratory rate's good, or heart rate's not too high, or blood pressure's good, and the SAT doesn't drop, and they're not so anxious and diaphragmatic that we can't get them off the ventilator. So that's all hard stuff to manage, especially the anxiety part, because a lot of people, if you have a tube in your throat, you're anxious. So, or you could use your end tidal. Did the end tidal go up more than 10? So we'll troubleshoot a few scalars here. So trigger asynchrony. So you can see right here, my patient's trying to trigger right out here, and they're not getting a breath. So sometimes that happens if the trigger is not set right. So that's the trigger is what makes the ventilator sense to give that patient a breath. So so if I have my patient set on a rate of 14 and they want to breathe 20, they're going to want to trigger or get more breath. So they're trying to breathe in, and so right here you can see that they tried to get a breath and they didn't get that breath. So sometimes that's due to maybe they have a little bit of obstructive airways and they're not getting all their air out, and sometimes it's due to the trigger not being set right, or maybe the flow isn't fast enough and they're not getting enough time to exhale before they can trigger another breath. So Auto-PEEP. So Auto-PEEP is not a great thing for a patient. So Auto-PEEP is actually intrinsic PEEP. So if I don't exhale all my gas out and I try to take another breath on top of it, I can have Auto-PEEP. I can create PEEP within my lungs, a greater PEEP. So that makes it harder for me to trigger too. So this could be part of that problem with that trigger. So you see how that this is the flow pattern. So look at that flow pattern. So it goes up, comes down, and then comes down here, and this is expiration. Okay, so it should come back up to 0 baseline. If it's not coming back up to 0 baseline, you know you have what's called auto-PEEP or intrinsic PEEP, and that patient's not going to be comfortable. You can't just keep building up pressure in your lungs and expect that patient not to work harder to try to breathe. So that's something you can look for in the flow pattern. Real easy to figure out, real easy to see. If this is happening, you can fix it by giving them their flow faster. So maybe they're not getting a big enough flow, or you can, if you can drop their tidal volume a little bit, which would give them their more time to exhale because it's taking less time to give the breath. Or you can drop your respiratory rate unless they're trying to trigger over that. So these are another way to do it is to change them to that square flow pattern that delivers the breath faster. So there are other ways there's ways to fix this, and there's simple ways, okay? So you guys can do this. I know you can. Auto triggering. So sometimes the sensitivity is set too sensitive, And so then the patient gets a breath, and then they get another breath on top of it, okay? Because the vet is just giving them breath. So if your sensitivity on your ventilator for the triggering is set too sensitive, then you are going to get multiple breaths at a time. And that's not good for the patient either. You're trying to not give them too much volume, give them enough volume, but not too much. And they're getting like double the volume right here. So flow asynchrony. So flow asynchrony is if my patient has a big demand of they want to suck that breath in quickly, and so you see it on the pressure waveform where they suck all that pressure out of that breath. You don't see it so much with this, but he's trying to suck all that volume out, and so that means this flow is not set high enough. So you got to try to give them more flow faster. So, and don't be afraid of flow. I typically use anywhere from 65 to 120 liters per minute. So you got to try to watch the patient and see what they're comfortable with when that's set. So that's what I do. I mean, and if you see your patient doing this, then you should go over that ventilator and increase that flow rate and see if you can't fix this. All right. Sometimes to fix this, you might go to pressure control, where pressure control ventilation lets them, any kind of pressure breath lets them have the amount of flow they want. They control the flow. So that's a good thing for that patient. The more control I can give my awake patient, the better off I'm going to be. It says here's rate asynchrony again, where the patient is taking breaths and they're not exhaling all the way. You can see my flow pattern here. It's not coming up to baseline, up to zero on the exhalation. So here's inspiration, and then it goes into exhalation on these blue ones. See how that's yellow and that's blue, and they're not coming up to zero. So my patient wants to exhale all the way, and they're getting anxious, and they're taking breaths on top of each other. And double triggering here, so you can see again. Here's that patient triggering breath here. Here they're getting a breath on top of a breath here. They're getting a breath on top of a breath here. So these are, when your waveforms don't look, and I know it's hard to see, but if they start looking jaggedy like this, that means something's happening with your patient, and you need to try to fix that. Here you can use these flow volume loops here. You can see if say your patient is has a chest tube in them, and this is inspiration, this is expiration. And if they have a chest tube, or maybe they have some chest trauma or something like that, you can see if they have a leak. If these two limbs do not come back together, that patient has a leak, okay? So you can see that on your ventilator. You can tell that before they even get that chest x-ray that they have a leak. So, or maybe you know they have a leak and you just want to see what volume it is. So if you measure from here down to here, you're going to see what volume that is. All right. So let's do a little case study here to end my thing. So I got a lady who's 67. She had a bowel resection. Her vent settings, tidal volume is 450. She's on assist control, volume control of 22. FiO2 is 35%. PEEP is 5. Descending waveform. So descending, you can see this right here. And then her flow rate's 38. All right. So we can look at this right now. I can tell you right here. See right here, she's not exhaling all the way up to zero baseline, right? So her flow is low, so she's not going to be happy with this. Nobody's ever happy. See this one right here? This one goes up the baseline, up to 0. So does this one. But then when you start getting into some of these breaths here, this is inspiration in the red, and she's starting inspiration when she still has flow left to exhale. So that's not good for that patient, and they're not going to be comfortable with it. And okay, so we increased the flow rate to try to fix that, to address her auto-PEEP. Now her lactic acid levels are rising. I don't know if you guys can do lactic acid there. And her minute volume increases. So she's trying to compensate for increased lactic acidosis. So that could be a problem for her. She needs maybe some more support or a different mode or something like that. So do you have any questions for this? I know you probably have a ton of questions, but I can see Juan Wilson, right?
Yes.
Yeah.
So
you look confused, and I'm sorry.
So I think there are a lot of questions. I think John, this is a great summary, and what I would advise or our learners on the other side is there's a lot of physiologic concepts that is really included in this presentation.
Yeah.
And it is important, therefore, for I think for everyone who attended this webinar to go back and read in the books a little bit more detail about all this physiology that was mentioned, and if need be, listen also to the recorded webinar so that you can really then understand some of this dynamics and some of this physiologic points that John has been raising to make it clear. And I think the physiology of ventilator management, just by webinar only is not going to happen unless somebody also on the ground, on the spot, is working with you, showing you the buttons, and actually at the bedside, if you will. So hopefully we will figure out and find ways to complement with what Dr. Theodros in Addis or other intensivists in other places are doing to teach their residents. So we hope this will really add a little bit more clarity to some of the buttons and the physiology and so on and so forth. So I would really encourage strongly for everybody to go ahead and please read some more. And we'll put these slides soon, and on the slides have been sent to you already, but the presentation will be posted on our webinar sites, and Malaku will be communicating that with everybody. And this particular topic requires really review and interest from all the attendees to go back and read and then listen again. So for me, it has been really a huge refresher for myself. So I would just want to give Dr. Wendosen a chance to ask questions if he has. Otherwise, we have actually plenty of questions from the audience. So I'm going to start with the first one. Dr. Wendosen, do you have some questions?
Yeah. It was an interesting. It was almost a revision of physiology as well as practical pulmonology, critical care medicine. But I would like to ask you, the Italians have introduced this helmet CPAP with COVID-19. So how feasible is that,
I'll be honest with you, I have no experience with that. We don't use it at all in our country. So I wish I had some insight for you. We actually were looking into some of that, but we have not used that as of yet. So so I really don't have much of a comment on that. I'm sorry.
No, good. No, it's okay. I think we can research it, and we can come back Wendosen to you maybe at our next webinar. And I think the next webinar is tomorrow for those of you, not tomorrow, on Friday. And I think Dr. Mola is going to really focus on non-invasive ventilation of hypoxia. So I think we can maybe add this question to him so that he can research it and come back to us with an answer. So I'll bring it up to him. So a few questions for you, John. So the first one here is, question is, can we apply rapid and shallow breath index for children? Any difference in SBT in COVID-19 patients?
Okay, so we don't use it on children at this point. And yes, we do use it on our COVID-19 patients. We are just like the other patients, we are trying to get them off as quick as we can. So we need to test them. We need to look at them and see if they qualify and then try this on them. We have it's usually hit or miss. And actually with your COVID patients, you're trying not to intubate them as much as you can. I mean, I'm sure you guys are too. It's hard to, sometimes when we intubate our COVID patients, that they actually do worse than they would have if we would have left them off the vent. So we're trying everything we can not to do that, but yes, we do use this on there. We use that screening tool with them.
Okay. So the next question is, if the mode is VC, how could flow time waveform be descending? Or is that?
I'll tell you. Am I unmuted? Yeah, I guess.
Yeah.
Okay. Okay. So it's the way it is set up in the ventilator. So we use a descending flow pattern for that. So what it does is it builds up quickly and then comes back down slowly. So the end of the breath, it delivers slower than the beginning of the breath. It's something that's programmed in the vent, though.
Okay.
And all vents should have that as a choice.
Yeah.
Okay.
So one more question is, anything we should do in terms of troubleshooting, when we have, peak airway and plateau pressures are all high. What are the things we have to think about? Oh,
okay. So things you need to think about is why is this happening? Is the patient in ARDS, or do they have pneumonia, or those kind of, you got to go down the pathway of what's actually causing it. PEEP can sometimes actually help by increasing your PEEP. And that's another thing. I mean, you get to a point with PEEP that you don't want to have too much, but if I was on 5 and both of those numbers were high and my lungs are stiff, I could maybe open up more alveoli if I increased my PEEP up a little bit and see if that doesn't change things. So if I increase my PEEP, like let's say I go to 8 from 5, and my plateau pressure doesn't change, I know that it's not hurting my patient. So I can go up a little bit higher and see where the point where I start seeing that plateau pressure go up, and then I can stop there, and then maybe my patient just needed a little bit of extra positive end expiratory pressure. So that's one way to do it. So, and maybe you could drop your tidal volume. You may have to drop. We now are maybe going to 4 mils per kg on our tidal volumes. So if you drop your tidal volume, you can increase your respiratory rate. Again, you're gonna have to adjust other settings, but maybe that's what that patient needs, is a smaller tidal volume and an increased respiratory rate.
So I see there are some questions about where do we find the recorded webinar and the slides. I think for that question to everybody, Malak will be sending links to the webinars as they are coming online, because we don't put them right away. It takes a couple of days to edit some of the slides because of the occasional noise we get. And particularly, I just want to ask everybody that's on now that next time you log in, please just make sure you are muted right away, because as soon as you come online and you're not muted, what happens is our recording gets a little bit affected. So with that, you will get an email sent to you with the link to the webinars. So they will all be online, either at the Ethio-American Doctors Group website or at the in a YouTube location. So Malako has been sending them, and I would ask him to send the link to all those webinars that are already online for you. I know Elias is online as well. So Elias, do you have any additional thoughts? I don't know when you joined, but if you want to say a few words.
Okay, thank you. Thanks, John, for the presentation.
Yeah.
So I think, Dr. Gurma, like you said, I mean, this webinar is not intended to make you guys a respiratory therapist or an intensivist. So I think the whole purpose is to just inspire you guys, especially for those of you guys who are in a position, whether fortunately or unfortunately, in taking care of patients on a vent. So it's very important to know how you can avoid hurting the patient. That is, I think that's going to be the next few series, including this one, is going to be very important to just point the things you can troubleshoot, like the pressure issues. I know the peak airway pressure. Just go to the patient and look at the vent, and as part of your clinical examination, it's very important, and at least have some idea what those numbers mean. I think, and that was a great presentation, and some of the curves will help you figure out, like he showed you guys, about the compliance, about air trapping, or Auto-PEEP, or intrinsic PEEP, because it's especially in taking care of people who have obstructive lung diseases, and you see patients have discomfort or asynchrony in figuring that out, what you have to do. So those numbers, I don't want you to be like confused with some rapid shallow breathing index. It's essentially the relationship between respiratory rate and the tidal volume. So you can see it in different ways. You can come up with that formula, respiratory rate to tidal volume, and the number less than 105, which again, there is no universal consensus, but that is a good number to start with. That meant, if you look at a respiratory rate times tidal volume, that means minute ventilation, by the way. So the relationship, what it means is it's your patient breathing too fast, working hard, but not getting enough tidal volume. So it will help you in assessing in the weaning process. So what I'm trying to say is that there are very key things you need to know if you have a patient on a vent. Try to avoid the harm part. But we don't expect, obviously, this courses to make you an expert on a ventilator. You need a fellowship for that.
Yeah. So I think let me see if there is in the meantime any additional questions that have come up. But I think you really raised a very important point, and I just want to also let everybody know that the session on May 8th is a panel discussion, and at that time I think all these troubleshooting pieces may be also brought up again, and I just want to ask Elias and the respiratory team, I think, to maybe think about some case-based kind of presentations, and if there are some specific case-based presentations with troubleshooting, that might really drive the message a little bit better to everyone to really understand a little bit more in depth the physiology that goes around this. Dr. Zerion, I see you are also online, and I don't know if you have been listening to everything. Do you have any additional thoughts and comments?
Thank you, Dr. Guma. I came part after John started, and actually enjoyed the rest of the presentation he did. And I want to say I'm very thankful for John, because I mean, he has been doing a lot of things to Ethiopian hospitals, and he told me about ventilator when I did my fellowship. So I can tell you he's one of the best respiratory therapists you can find out there. So thank you, John, for this wonderful presentation. And, saying that, what I would like to say here is, I think, the ventilator, I mean, is simple and complex, I mean, I think if you think it as like very complicated, I mean, you get scared of it. But I think the more you see a patient and be at the bedside and see the flow, the waveforms, and how the patient interacts with the ventilator and so on, you would really understand it. And it's not hard. Basically, ventilator means it's just a blower and a timer. So those are the two things. It's just, and then the other things are more additional stuff. And by just standing at the bedside and looking at the waveform, you can see what the patient is doing and what the ventilator is doing and how they are interacting, and you can help this to be synchronized so that the patient will be more comfortable. But the only way to and standing by the bedside and just observing with mostly without touching. So otherwise the theoretical part is difficult to really retain and so on. So I encourage you to do that. I encourage you not to be afraid. It's not as complicated or huge as you think. It can be simple, it can also be complicated, it can be dangerous. So you have to know what you're doing, and the overall purpose, we should, as we always said, is if you can, try not to put the patient on the ventilator. Once you put the ventilator, try to shorten the time on the ventilator, because staying every day on a ventilator is very risky and dangerous. And try to make the patient comfortable through that process. So, but great presentation, and I think if any question, I like, I'll try to be part of the answer.
Yeah, I think one of the questions that was raised, maybe we can answer the question either on Friday or afterwards, is that Dr. Wendozen wanted to learn and know more about the helmet CPAP the Italians are doing right now. And I think it sounds like something created or manufactured for the COVID era, probably isolating the ventilation.
I think that's patented by the Italians. They probably prevented being exported and so on. So in US we don't have the experience, but now since it's easing in Europe, I hope these things will come to Africa, Ethiopia, and so on. So but I haven't heard any in US anyone experiencing it. I don't know, Elias, if you have gotten, or Dr. Gama in your place or anywhere.
No.
So
no, we don't. I have not heard about it, and I don't know if Elias has any additional knowledge, but we can maybe look into it and come up with, how it works and so on and so forth, and figure that out.
So I got to get to work. So
okay,
I'll see
okay,
you guys.
John, we really appreciate your help, and there are maybe when you come back for the panel discussion on May 8th, maybe one ask I have for you is maybe if you can have a slide or two to go from the scalars to the mode of ventilation, for people to see, that way, they can look at, the scalars and say, okay, this patient is on this kind of ventilation. If there is a way to reverse stitch it, I think that can help them also understand, a little bit more. I don't know if that makes sense.
No, it does. I
Okay.
get it. Okay.
Perfect.
I'll work on that.
Maybe a couple of slides on that during the panel on February, on May 8th. That's a Friday.
Okay.
So I appreciate you being here and thank you so much.
Thank
and,
you.
And I think for most part, we have also exhausted the questions. Tomorrow, on Friday, we are going to have Dr. Mola, who is going to talk to us about general management of hypoxic respiratory failure, oxygen therapy, and non-invasive ventilation, all the CPAP and the BiPAP and high flow nasal cannula and initiation of mechanical ventilation. So I think this is going to be very practical, both from the diagnostic as well as therapeutic point of view for our situation in Ethiopia. So we're looking forward to seeing you at the same time at 3 p.m. your time. And as usual, we'll try to get started on time. Please remember, when you join, you can ask questions through the chat system. And please mute your phones and your computers so that we can have our video quality the best it can be for you guys to review in the future. So thank you, everybody.